Hello, everybody. It's 2 o'clock Netherlands time. So this is the time that we're starting the webinar. My name is Paul Jansen, and I'm your host tonight on behalf of Wemos and Cordaid, two organizations from the Netherlands working in global health. And we are delighted that you are here. There's still people signing up. As of now, there's over 40 people registered or joining. There's many more people registered, but they'll join later. Because we have a lot to cover, we're not going to wait for a couple minutes until everybody is there. So once again, very much welcome on behalf of Wemos and Cordaid. Just to give you an overview of why we are here and what we are planning to do. Wemos and Cordaid have jointly undertaken a piece of research to look at the 3 Gs, i.e. the Global Financing Facility, Gavi, and the Global Fund to fight AIDS, tuberculosis, and malaria, and specifically looking how these organizations are coordinating with each other and how they are aligning their work with the governments and the ministries of the countries that they're supporting. They have undertaken this research because both of them are quite active in policy dialogue and advocacy, not only towards the Ministry of Foreign Affairs of the Netherlands, but also towards the 3 Gs themselves and other donors of these global health initiatives. The objectives of the webinar today are for the researchers, first and foremost, to share their findings, conclusions, and recommendations. We are very fortunate that we also have representatives from the global health initiatives to reflect on those conclusions and recommendations, as well as people who are from the countries that those global health initiatives are working, so we can also get reflections from people who know what's going on in the field. We have 5 quarters of an hour. We will stop sharply at 3:15. Netherlands time. I'll just run you through how we organize this time. First, we get a presentation from a representative of the Ministry of Foreign Affairs from the Netherlands to set the scene. Then we'll get the presentation from the researchers. Then it will be time for reflections from the representatives from the global health initiatives, as well as the people working in country. And after that, there will be ample time for reflections from yourselves, the audience, through the question and answer session, and then we will close. A couple of housekeeping things. For those, everybody should know that we are recording this whole webinar so that we can share it later with those of us who haven't been able to make it today or who have to leave early. We will be using the question and answer function. If you look at the bottom bar of your webinar, you will see the Q&A. By all means, use that function to ask questions to any of the presenters. And it's also quite important to know that if you see questions that you really think are important, like them and vote them up in that way so that they are more likely to be addressed in case we don't have time for all the questions. At the same time, you'll also see in the bottom bar the chat function. The chat function is open for everybody to talk to everybody. So by all means, find out who is here in the audience and chat with one another. We will also use the chat function from ourselves to notify you of things that are happening, who's speaking, and we will share some links and suggestions there. And you should also know that we will be doing some Mentimeter polls. So if you are familiar with Mentimeter, be prepared. And if you're not familiar with Mentimeter, don't worry, we will talk you through it when we get there. So that's the introduction. Sorry to make it so long. I won't waste your valuable time. We are going to now go to the first part of the webinar, which is a presentation from Marja Esveld. Marja is representing the Ministry of Foreign Affairs. Marja is trained as an epidemiologist in infectious diseases, and she is the lead of the global health team at the Ministry of Foreign Affairs. And she has been working for a long, long time in global health. She has been working at the WHO, at the Ministry of Health in the Netherlands, and also some other governmental bodies. And she's not unimportantly, she's just coming out of a board meeting of the Global Fund. So she's also quite familiar with the governance of the global health initiatives. We asked Marja, because the Ministry of Foreign Affairs is such an important donor of the multilateral health programs and global health initiatives, and the Ministry of Foreign Affairs is also very committed to health system strengthening. We asked her to reflect on what is the vision of the Ministry of Foreign Affairs when it comes to the 3Gs strengthening national health systems. And with that, I'm going to give the floor to Marja.
Yes, good afternoon, everybody, and thank you, Paul, for this nice introduction. Indeed, it's very busy at the moment with Global Fund meetings, so I'm just jumping in and out of kinds of calls. To be honest, one of the main discussions currently in the Global Fund is around health system strengthening, and how do we define health system strengthening? Is it just a way of working, or is it a goal on its own? And I think by having these in-depth discussions, many of the issues that the report from Wemos touches upon cross the discussions. And let me just first start by thanking Wemos and congratulating them with the wonderful report. I think it's an excellent piece of work. It's also a piece of work that I think many of my colleagues and myself would have loved to do ourselves if time permitted. So we are also very grateful for Wemos and their colleagues to just, you know, grab all the information from the different funds and do this analysis. And I think it's a very useful piece of information. I think we're also very much aligned with what is in the report. And we can certainly make use of its recommendations, and we will. At the same time, many of the recommendations in the report also have some inherent tensions. And I just wanted to use these few minutes to highlight some of these tensions and not to say that we cannot make use of the report, but just to show or to illustrate that sometimes well, practice is harder than theory in a way. And maybe this may also give you some food for thought for today's webinar. If I can just highlight some of the topics that are in the report. I have written down a few, so if I look to there's my screen, sorry for that. For instance, that one of the recommendations says it is essential to ensure that approaches to hard to reach people and underserved populations have to be maintained as we move to domestic national health financing. I think everybody in this call agrees. At the same time, the question is, how do you do that? If we want to put countries in the center of the work, and if we really aim for country ownership, at one point in time, we have to let go. And what point exactly is that? Is that the point when the country does exactly what we say them to do, and then we feel comfortable and then we let go? Or do we accept certain own interpretations of countries, for instance, around human rights? Well, that is a very hard question. I mean, we all feel that in order to combat HIV/AIDS effectively, we have to address the needs of key populations. But what if in a country some of the key populations are criminalized or are just, they do not exist according to the government? And then you can end up having a discussion around what country ownership really means. And for us, it's very hard to strike the right balance there. The other thing, that's the issue around health, around the financing of salaries, for instance. We have had a discussion also internally with our global health team. Do we do we indeed push for more flexibility around the use of recurrent, the funding of recurrent costs as is recommended in the report, for instance, for salaries? Or do we principally say that salaries are such a basic health system function that it should be covered by the government, because if it is funded by funds, it's too fragile, and if a fund steps out, we risk the health system to collapse. So, and I'm sure that is also not what is intended by this recommendation. But then the question is, what is it? What can we do to make sure that while we remain flexible, at the same time the government takes their responsibility? And I think one of the recommendations made by Wemos is also something that we push for quite heavily, is that the global funds, even though they are funds by definition, have much more influence also politically than they perhaps think of themselves, or how they profile themselves. I mean, just look at the Global Fund, an organization that is spending 4 billion per year at country level does have a lot of leverage, also politically. And we have to make sure that this is used in the right way. Yeah, maybe just because time is moving quickly, maybe one more thing that I wanted to mention that relates to the conclusion that we have to rethink attribution. We really support this conclusion. We think it is very important that we well, become a bit more flexible in how we monitor our own contribution. And it's not always the best for all to make sure that we get a clear picture on how our individual euros are being spent. And if we have the option to become a bit more flexible there, then we can say, well, it doesn't really matter who is paying for this individual bed net, or for this individual ARV, or for this individual prevention program. It's more important that it reaches its goals and that it creates impact. And it is important that we contribute to this program, but it's not that important that we know exactly what is being paid by the Dutch government. But that also is quite complicated, since we have a parliament who really asks us to be very specific on the contribution and attribution of all our investments. So, but nevertheless, I think this is an important discussion that we need to embark upon, not just with the funds, but also, yeah, with the parliament and with stakeholders within our own country. And this is something that we are certainly willing to do so. And we can also work together closely on this specific topic, because it's sometimes difficult for a civil servant to convince your politician or to convince political partners that things work the way they work. But here I think I see a clear added value also from the civil society to help us supporting to get this message across. So maybe I should stop here. And again, thanks a lot for the great work, and I'm really looking forward to today's discussion.
Thank you so much, Marja. This was a wonderful way of getting us all thinking about some of the recommendations from the report. I just remind the audience, use your question and answer button, because already Marja has been giving us some things to reflect upon. We're running late already, so we're going quickly into the Mentimeter. Please, you see on your screen and also in the chat, the code for the Menti. Just go to menti.com, either on your browser or on your smartphone, push in the code, and you will get a question. And the question that you will get is, which of the Gs are you most involved with? Are you most involved with the Global Fund, with Gavi, or Global Financing Facility? And be aware that you can pull in more answers than one. We just want to know who's in the audience. It seems the Global Financing Facility is the preferred partner for most of you. If you have answered this question, please go to the next one. And the next one is going to be the question, when it comes to coordination, have you seen any improvement? Have you seen improvement at global level? Or have you seen improvement at country level? Or have you not seen any improvement? Just so you can, for each of the levels that are relevant for your work, you can identify how well you would score it on a scale from 1 to 10. And what we will see is the average. And if we look at the average of the people who have been responding, we see that coordination is actually probably taking place better at the global level than at the country level, which probably doesn't come as a surprise to the organizers. And if you then move to the next question, we are asking you to mention in 1 or 2 words what you actually think are the main challenges when it comes to cooperation between global health initiatives. So just dot in 1 or 2 words and we'll get a word cloud and see what is the most popular thought on this one. Whoa, there's a lot of things coming up. Duplication, shouts out. Well, of all the problems in coordination, it seems that most people have been talking about duplication, and now competition is actually coming up, donor competition and different donor priorities. Okay, that's really good. So that's getting a bit of a feel for what we think about and what we have experienced in donor coordination. So let's move on to actually a presentation about of the research. Mirja Kutsumpa, who is one of the researchers, is going to present. Mirja is a global health advocate at Wemos. She's focusing in the Wemos program on fiscal space for health, financing human resources for health and global health initiatives. And especially her focus is on the global financing facility. For her work, she analyzes policies and decision-making processes, and she engages in advocacy with others, all with the purpose of strengthening health systems for everybody. And for those of you who have been looking at the report, you see that there is an enormous amount of findings, conclusions, and recommendations. And to focus the discussion, we've really asked Mirja not to discuss everything, but to really focus on some of the issues that she thinks should be focusing and guiding the debate for today. So take it away, Mirja.
Thank you, Paul. Thank you, everyone, for being here. It's great to see such a big audience, which means that really this discussion is really, really timely and really, really relevant to a lot of work that civil society has been doing. And actually, this was also one of the main goals of this work that we started together with Cordaid, to provide evidence to civil society organizations so they can use the information, they can use the knowledge for their advocacy towards the 3Gs, towards their governments, but also to bilateral and multilateral donors. So if I can get the next slide. Perfect. So why we decided to embark in this project and do this paper? So first of all, these 3Gs that we are talking about today, and I saw from the Mentimeter that a lot of you have some sort of relationship with them. They're really the largest global health initiatives now, and they have the capacity to really increase resources for health massively, but they also have the capacity to influence national policies, and ultimately they can impact the lives and well-being of people around the world. And as Wemos and Cordaid are also Dutch organizations based in the Netherlands and also engaging in advocacy also at this level, we found it really key because the Dutch government, as also Marja said, has invested a lot of development resources to all the 3Gs and also has a seat at the decision-making table of the 3Gs. But what is also important to know for everyone is that this report, this findings, the discussion that we're having today is really the first step, because as also the Mentimeter showed, even if coordination is improving at the global level, what really matters is how it's played out at the country level. And we saw that at country level, the score was lower. And that was something that we identified from the beginning. So that's the first step, because after that, we want to do country cases to really see how everything that we're going to discuss today really play out on the ground. So to start with, just for an introduction, this coordination we're talking about, it's really no big news. We have been talking about this for many years. Over the last 20 years, we have seen a lot of global health initiatives coming up. Gavi was established in 2000, then the Global Fund followed in 2002, and last but not least, we got the GFF in 2015. And over the years, there have been various global commitments and agreements from the IHP Plus back in 2007 and the Principles of Aid Effectiveness to the UHC 2030 movement, and most recently, the Global Action Plan for Healthy Lives and Wellbeing for All, that really renewed this global commitment for coordination. And you will hear us repeating that a bit today. And also, this is why we have also invited Hendrik from the GAP Secretariat to talk about this today. So how did we end up to this webinar? We started doing basically desk research and analysis of documents that were publicly available related to the 3Gs. So their strategies, technical briefings, policy papers, communication materials, up to and including November 2020. Then in February, we organized a focus group discussion with experts from civil society, from academia, from the Dutch Ministry of Foreign Affairs to basically get their feedback and validate our areas of attention and our recommendations to know that we are on the right way in our content. And we got really, really useful feedback from them. And of course, we also shared that draft with the 3Gs themselves, because we wanted to check for factual accuracy, and we also got really valuable feedback from them with also very important resources that we had probably missed during the research, and it was great to receive them. So we also included some resources after November 2020 when we considered that, okay, that's really key, we cannot not have that in our report. And of course, that led us to today's launch of the report. And as I said, that's the first step, because really the goal of it is go to the countries and see how everything plays out here. So if you're attending this webinar and you have examples from your country context, feel free to reach out to us and share your experience with us, because it will also really help us continuing this, this project. So let's see a bit the main findings. So the idea, the framework that we use for our analysis was inspired from the WHO 6 building blocks for health systems. But from them, we picked 4: health finance, human resources for health, health data and information, and supply chain management. And then, because we really wanted to highlight inclusion and equity there, we also added community engagement and gender as focus areas of our analysis. In the report that my colleague shared in the chat, you can find a lot of information per topic, per global health initiative, what we found in the desk analysis. We saw what the 3Gs have in common, what's the differences with them, and then that led to the recommendations that is only part of the report, really, what I'm going to present today. So I will take these blocks that you see on your screen one by one, just highlight what were some common findings of the 3Gs per topic, and highlight some of the areas of attention that we identified. Health finance was really a very large topic, so I'm going to address it separately here. And I want to highlight that health financing is really an area where there's huge potential for the 3Gs to coordinate and collaborate, and they are already doing it, because there was a whole accelerator under the Global Action Plan, that is the Sustainable Financing for Health Accelerator. And they have been doing a lot of work under that, including also building a capacity of CSOs in budget advocacy. And we have been following that closely. When it comes to the content, so what we found is that the 3Gs, they all consider domestic resource mobilization important. They all consider sustainability important, and also the need for countries to be able to co-finance the programs. We saw, however, that they all focus a lot on improving efficiency and improving public financial management a lot when they want to highlight the better utilization of domestic resources. They all explore also innovative financing mechanisms that also include blended finance. And they also explore how to better engage the private sector in health service delivery, in R&D, in all the aspects of a health system. So they share this. And some recommendations that have to do really with the health financing is what Maria mentioned in her opening about not forgetting the hard to reach and underserved population when we move to domestic national financing. And when we're talking about pooling of resources for health system strengthening, we were thinking that even if it's not possible to pool all the resources of the 3Gs under a national health basket, at least it could be possible to pool the health system strengthening grants that they all have in their programs under national health baskets behind a joint health financing approach. Something that we would like the 3Gs to be cautious of is about public-private partnerships in healthcare and really prioritize what can be done by putting public first approach to health financing first, and then resolve to private sector engagement. And the last one, and I'm going to highlight again in the end, is also something that we consider really important, that beyond public financial management and efficiency improvements, there are also other ways to expand fiscal space for health. And even though they maybe not be in the immediate mandate and program of the 3Gs, we were thinking how they could engage with these ideas and even advocate for these ideas. But I will come back to that in the end. Next slide, please. So if we move on to the human resources for health as a system component, here what we found, next slide, thank you, is that all the 3Gs, having an eye on sustainability, discourage recurrent costs, including HRH, human resources for health salaries. It's not forbidden, but we saw that they are very cautious with it. But they all recognize that the health workforce is really a key component of health systems, and they all support pre-service training, in-service training, providing PPE equipment and everything. But we thought that there could be more flexibility in the allocation of funds in salaries for health workers, knowing that there is a challenge for sustainability there. And of course, what we see is that big players and big NGOs can cause labor market distortion in countries. So we need to really adopt a do no harm approach to that and be open to the potential that technology can bring to us. Next slide. Thank you. So regarding data, that it was really key, we realized, because you cannot fix what you cannot count is something that we saw coming up a lot. And all the 3Gs give a lot of importance onto the data. They are all participating in the Health Data Collaborative. They use data for transparency and accountability. They all disaggregate the data and they try to align with the countries. So we want to highlight that aligning with with national processes of data collection and M&E can really lower transaction cost and the burden on national authorities. And by counting everyone, we wanted to highlight also that if we really want to leave no one behind, we need to apply an intersectional lens to the data and information management systems. Because otherwise we might leave behind people that, due to intersecting identities and intersecting vulnerabilities, they are led to marginalization. And of course, always respect sensitive information and privacy. And for the supply chain management, that was another part of the system components, what we wanted to point out here is the need for integration with community service delivery systems. All of the 3Gs discuss supply chain management, because it has to do also with commodities, with vaccines, you name it. But what we wanted to point out here is really the point on integration. And then moving on to the part that we included to ensure the lens of inclusivity and equity is the community engagement and gender. And community engagement, and I'm going to put also here civil society engagement, it was really important also in the GAP. Like there is a whole accelerator on it in the GAP. So it's really an issue that has everybody's attention nowadays. What we consider important here is that communities are not just receivers of services and extensions of service delivery when it's needed, but they are really integrated and part of the health system. So integration is again the key word here. And there is a huge potential among the 3Gs to integrate community service delivery and also ensure that local communities and local CSOs have their own voice and they are not just substituted by voices from global CSOs and big NGOs. And really, all the 3Gs share a lot of good things, like they all involve civil society in a lot of their processes. They recognize the role of civil society in service delivery. They all have country coordinating mechanisms, each one with their different name and maybe different structure, but it's there. And it was great to see that also very prominently in the GAP. And really community engagement was a point that was really, really highlighted in also our focus group discussion. So that's why I really wanted to stop here a little bit. And then last but not least, we also saw what is the approach of the 3Gs when it comes to gender. And we saw that gender equality was key in all of them. They all have sex disaggregated data in their reporting and in their data systems. And however, they had different approaches on a different definition of gender. So that could be mainstreamed. And what we consider important here is, first of all, that they should continue to be reviewed by the Global Health 50/50 Index, which they are already doing, and it's great. So they should continue that. And then commission routine assessments of the impact on gender equality of the programs with aiming to a gender transformative approach. And this was really key. Of course, it was great to see gender really in all of the 3Gs documentation. So overall, I presented really the areas of attention, the main findings of all the components, but really the key is for the 3Gs and global health initiatives in general to coordinate and move from complementarity to synergy. And now we'll finish the presentation with really some key overall recommendation about coordination that I would really like to hear also the rest of the panelists reflect upon. So as I said in the health finance chapter, we consider really important exploring new ways of expanding fiscal space for health if we really want to see domestic resource mobilization seriously and really increase the pie of domestic resources and therefore the ones allocated for health. I know this is not in the mandate necessarily of the 3Gs, but we envision that they could be advocates for such a change, like advocate to other international, to international financial institutions about this approach. So they could support that as a vision. And then, and that was also important when we think about to measure what we want to change, is that global health initiatives can create strategic indicators on coordination and alignment with countries' priorities. I know already the GFF with a new strategy has a very strong focus on alignment and even a working group on that. But there could be also a link with the M&E framework of the GAP that is currently being finalized, and maybe Hendrik can share some thoughts on that as well, on how to mainstream all this measuring of coordination. And then what was highlighted also by Marja, and we really think it's in the center of this change of thinking, is rethinking attribution and move away from the need to put a stamp of every donor to an outcome and aim to see. The point is that all the donors work together to basically serve the national health priorities, even if they don't necessarily see the stamp of the GFF, the Global Fund, the Gavi on an outcome. And that goes also, as Maria said, for bilateral donors. And of course, lighter procedures for proposal development and reporting would remove a lot of burden from the countries and make their lives easier. But really, it could become even a mode of this rethinking attribution in the global health arena. And I'm going to end with that. So I will be happy to see your questions. As I said, that's just the beginning, and we continue this process of research with country cases. So it would be great to hear experiences from everyone. So over to you, Paul. Thank you.
Thank you so much, Mirja. This was a very clear presentation, very comprehensive, and within time. That is fantastic. Thank you so much. As Mirja said, I just want to remind the audience that we have a question and answer function at the bottom. There is the chat, but please use the question and answer for your questions that you have, either to the whole panel or to individual panelists. We are going to do our best to address as many as possible questions. If we are not able to do them within the webinar, we will definitely take note of them and try to answer them for you. At the same time, I would also like to remind the panelists that you can already answer some of the questions. Some of the questions are quite simple. So if you answer them, then we don't need to deal with them in the webinar anymore. So have a look, panelists, as well. I know that there's already a bunch very specifically addressed to what Maria has been saying earlier. Okay, that out of the way, I'm going to announce the first reflector from the Global Health Initiatives. That is Hendrik Smits-Guinote. Hendrik is the coordinator at the WHO of the Secretariat of the Global Action Plan for Healthy Living, Healthy Lives and Well-Being for All. Quite a mouthful. It's the GAP for short, for those of you who haven't heard about the GAP before. Before Hendrik joined the WHO a couple of years ago, he worked at the German government at the Ministry of Economic Cooperation and Development as a counselor for development policy at the mission in Geneva, and also as the coordinator of development assistance for the German government in Afghanistan. We asked Hendrik to specifically reflect on how the GAP coordinates the 3Gs, because that's really the mandate of the GAP. And also to have a look at the recommendation that Mirja earlier said about specific indicators for coordination amongst the health initiatives and alignment with national policies. So with that, I give the floor to you, Hendrik.
Thank you, Paul, and thanks to the colleagues at Wemos and Cordaid for bringing us together today. Shall we go to the next slide? Yeah, so that's the very complicated title. In short, it's Stronger Collaboration, Better Health. And to the next slide, please. And it's basically a commitment of 13 multilateral agencies. ILO joined the other 12 in January this year to better support countries to achieve the health-related SDG targets. SDG3 at the heart, but of course also recognizing that there are many other targets across the other SDG goals. And of course, increasingly now in focus also in helping countries recover from the impact of COVID. It brings together UN agencies and non-UN agencies. And I think that's one of the unique features, and the non-UN, many of them are among these 3G, which this webinar is focused on, but then also the UN partner agencies, so both the technical agency side and the funding mechanism side in health. And the Global Action Plan is also not a commitment to bring new funding, but really to make the funding which exists in the health system work better. And looking at the way of working across these agencies. It was launched in September 2019, before COVID hit the world, and brought many countries even further off track on achieving the health-related SDGs. Although there was already, of course, a concern in 2019 that the rates of progress were not sufficient enough, and that's why the Global Action Plan was conceived with an initial commitment signed in October 2018. And we released the first progress report in September last year, and we're actually working on the second progress report, which we'll have ready by the World Health Assembly in May this year. Next slide, please. And the implementation of the Global Action Plan is very much focused at the country level. And this observation from the earlier poll that coordination at the global level seems to be advancing better than at the country level. It's probably also one of the reasons why this strong country level focus needs to be in place. The Global Action Plan basically has 4 broad commitments: engage with countries and align with their policies and priorities, accelerate through thematic work along 7 so-called accelerator areas, and on gender equality as a cross-cutting commitment. And we'll get a bit more into some of those, but sustainable financing for health is one of these accelerator areas. And I expect Ellen will speak to that. And then primary healthcare, but also other areas which were mentioned, like community civil society engagement, but also the data system strengthening as important areas. The third area is the align, and a lot of this alignment actually happened through the joint engagement at country level and through the different accelerators. But there are also a few of elements happening at the global level, sort of working with the ecosystem. And I think one example relevant also for today is how the data accelerator under the Global Action Plan is coming together with the Health Data Collaborative in countries, really to work hand in glove in helping to strengthen health systems in countries, wherever countries express and request such collaboration to happen. And then account, and that's the progress report. That's also, of course, the monitoring framework, which we're currently developing and which will, for the future, then provide additional input and feedback for the monitoring reports. And just maybe in concluding this initial sort of broad focus on the Global Action Plan, what it is, I think one key element for such an initiative, which is based on self-commitments, are of course the incentives provided by the broader system. So one is, of course, countries demanding and a closer collaboration and providing leadership on coordinating the different initiatives. So of course, embedding this closer collaboration into the work, everyday work of the agencies. It's not something you should do as an add-on, but it's in a way you are always aware that you're working in a complex environment with many partners. And then the last piece, of course, very relevant. Each of these organizations coming together in the Global Action Plan has its own board, has its own, in a way, member state structure, donor structure, and the incentives these boards and the donors provide and the requests they formulate in terms of collaboration are, of course, very important to make these collaborations happen and successful. And I think it was very good to hear also from the Netherlands where priorities are for the engagements. And just to very briefly describe what we set out in the Global Action Plan as the success areas for 2023. So it's a better coordination of the agencies in global, regional, and in-country processes, a reduced burden on countries as a result of more aligned policies. And one example for, can be the PHC operational framework, which is being finalized and then provides a joint set of tools for everyone to use in strengthening PHC. And then, of course, a focus on purpose-driven collaboration integrated into the organizational cultures. With that, let me just react to a few of the findings of the report. I think overall, very important piece of analysis, of course. And
Hendrik, you want to be quite short in your reactions, you know?
Okay.
Go ahead. Take the most important one.
Yeah. I think on the overall one point, of course, UN agencies are also a key part of it. When you look at the finance accelerators or WHO, ILO now are parts of it. So the collaboration needs to be a bit broader than just the 3 Gs. And I think that's an important development the GAP has brought. On the strategic indicators, I think that's a very valuable discussion. I would be also interested to hear from the other participants how you would see that and what role the Global Action Plan progress reports and the monitoring could play in that. So no clear recommendation from us, but interested to hear. And then this issue of rethinking attribution. I mean, that's really key also when you come together as the Global Action Plan effort. What we want to achieve is impact, so better health at country level. And we want to facilitate that through better collaboration of the agencies. So in a way to measure the real impact of your work is extremely tricky. What we're doing in the progress report and also in the monitoring framework, using a multi-methods approach with country case studies, really to look a little bit deeper, but also a way to capture country feedback through questionnaires from governments, civil society, and then of course self-assessments of the agencies, checking of the processes. And I'll stop here.
Thank you so much, Hendrik. And sorry to cut you off because we totally appreciate how important the GAP's role is and how difficult it must be to be heard in GATS. And thank you everybody for putting in your questions. We have 15 as we go, and please upvote the questions that you like. So the next person reflecting on the recommendations of the report is Ellen van der Poel. On behalf of the Global Financing Facility, Ellen is working at the GFF in the health financing work stream, and she's working with countries to increase the domestic resource mobilization and to improve efficiency of their health spending. Before she went to the GFF, she was associate professor in Rotterdam, and her research focused on evaluating health financing reforms and measuring, importantly, equity in health. So the floor is yours, Ellen. 5 minutes.
Thank you, Paul. Yes, thank you all for inviting me. A lot of my comments actually have been made already, so I think I can be brief. Thank you for inviting me to this important discussion. I just want to express gratitude to the authors for producing this report, and also flag that I fully agree with some of the key recommendations that have been stressed. The need to move away from single attribution to supporting a common narrative, the need for longer budget cycles, pooling of resources as much as possible, and be explicit about indicators that measure alignment. I think those are great points to be made. So thank you for that. I do sort of fully agree that health system strengthening can only be achieved through collaboration and without attribution. But I think it has to be realized that it goes against still the DNA of the agencies, right? I myself represent the GFF in the Sustainable Health Financing Accelerator. I see great willingness and great progress, but we are sort of working against the DNA of some of the agencies. So in that sense, I do think the global health infrastructure needs to be changed a bit and make alignment much more of a core sort of focus of all of the agencies. And this is where I think donors such as the Netherlands that we heard from in the beginning could play a very important role in setting these incentives straight. With the GFF, we very much tried to be not a vertical fund for women and children, but really use health system strengthening as the common approach. So we really try to improve sustainability, efficiency of systems, to improve indicators, often for women and children, because we are focused on the lowest income countries where these represent the bulk of the disease. I do think though that the report perhaps doesn't do enough justice to the in-country and regional collaborations between the institutes that are happening already. I think this is a bit more difficult perhaps to see and to understand, because we very explicitly within the accelerator try to not earmark or label accelerator work or gap related work, right? We very much agreed from the beginning this should be a back office function that we as agencies work on and try to make things more efficient for governments and other partners at country level, but we don't launch a new process or label things as being accelerator driven or gap driven. So that might make it sometimes not very obvious what the gap or the accelerator is doing at a country level, But I do think that there's a lot of in-country progress that sort of results from this work. We're doing a lot of joint advocacy. Also, the CSO budget training was referred to. A lot of other sort of aligning technical instruments. We're trying to work on more co-financing arrangements in some countries. So a lot of this is actually is happening without there being a label to it. I just wanted to flag that. And then my second point that I wanted to make in this intervention is specifically in relation to the domestic resource mobilization agenda. I think this is the example where we need to move away from disease or population-specific advocacy. There's only very few moments you have discussing with ministries of finance and budget. And then at those moments, I think all the partners need to come with one message that's very coherent and that talks about a package of services delivered at often the primary healthcare level and not get into disease or population-specific advocacy. So here is also where I struggle a bit with how that is then represented in the report, right? On the one hand, if we agree to stop doing too much attribution, especially in the DRM field, then the question also sort of should be turned around a bit. And I think we should be then start to look at the extent to which all of the agencies are contributing to that joint advocacy, rather than trying to map out what all of them are doing. I think there are some good examples of that. I work myself a lot in Côte d'Ivoire, where I really see how the global health agencies came together around joint messages, where, for example, the Global Fund's co-financing policy is linked to a target in the investment case. Other countries in our portfolio in Kenya, where the IDA World Bank money is linked, disbursements are linked to specific DRM indicators. In Mozambique, there's a pooled fund linked to DRM targets. So there's quite different mechanisms and setups that we try to support to both advocate for more domestic resources for health and financially incentivize those increases. I do think it's important to recognize that this is country specific and we need to meet countries where they are. So we try to not do too much of the Abuja level generic target setting, but really sort of look at what is feasible in a specific country, what can they realistically do, and then what are the key flagship programs to spend on, and how do we help advocate spending on those rather than having more general targets. And then finally, so we're trying to really do this with the GFF through the work on resource mapping and expenditure tracking. So what we try to do, we heard already from previous speakers that data is really key. You can only advocate what you advocate for, what you can measure. So really being able to measure the domestic commitments to key priorities in a more sort of real-time basis is really critical. And this is what we're trying to do to the resource mapping expenditure tracking work, where we try to map out the extent to which donors and governments are contributing to country set priorities in these investment cases. So this slide, for example, shows you for selected countries the trend in these commitments. So you see, for example, for Ethiopia, the full donut represents the full cost of the investment case. And then you see the extent to which government donors are contributing to those priorities. And you also see quite a significant resource gap because it shouldn't be underestimated how difficult it is to prioritize these national health plans. And the slide gives you some indication of trends. I don't want to talk about the exact numbers or the country specifically in this short intervention, just want to stress that we are really trying to move away from specific advocacy to really mapping out resource flows behind the national health plan and trying to also hold the governments accountable to investing in those priorities through this exercise. And I think this sort of data, as we are collecting it for much more countries on a regular basis, can also be really useful for CSOs and other agencies wanting to contribute to this agenda.
Final thoughts, Ellen?
Final thought. Oh, yeah, I'm actually really finished. Just want to say that this data, we'd be happy to share more of that with interested organizations. People want to contribute to this work, because it can really be a powerful entry point to discuss about public financial management, monitoring alignment, and do advocacy with CSOs. So let me stop here then, and I'm happy to respond to any questions or follow up. Over.
Wonderful. Thank you so much, Ellen. I actually have a question, but I'll forego that. because we have only very limited time left. And so I'm also asking the next speakers to really please stick to your five minutes. The first speaker who is actually talking on behalf of the people who are actually working in the field is Andrew Ngugi. He's from Cordaid. He's the health manager in South Sudan. Andrew has been working for many, many years in public health at the highest level, but also at government level and at grassroots level for the last 9 years in South Sudan, although he is Kenyan by birth. And he has been involved in the Global Fund and Gavi projects in that country. So please, what is your experience in South Sudan, Andrew? The floor is yours. 5 minutes.
Thank you very much. I'll be very brief. South Sudan, as you see, is in a conflict situation. And for most of this, the Global Fund and Gavi have what they call zero cash policy for health ministry at the moment. Cordaid has worked with the Global Fund and Gavi, both under UNICEF and Health Pool Fund. In terms of what I can say is the grassroots activities, I'll go to Gavi. Gavi has integrated into the existing health systems and funding mechanisms, while Global Fund is still a parallel project with two principal recipients, one for TB, HIV, and one for malaria. This could change and there will be one principal recipient. The funding from both is able to support the health service delivery in the country, and this has sustained healthcare system in the conflict, as currently most of the funding, over 90% of the drug supplies and even staffing, is from grants, including both of the grants. The health system at the national level is not optimal to the required capacity, and we have seen that from 2016, the capacity at the national level reduced due to conflict, and this has not really come out. Both Gavi and Global Fund are not represented in the country. What they do have are regional representation somewhere in Nairobi and other places. And as we say, Gavi Fund is working through fund managers, UNICEF and Health Pool Fund, so it's able to reach the grassroots through a grassroots of NGOs. Gavi also is able to work at the grassroots level through the county health departments. For Global Fund, they work in a parallel situation where they are the ones implementing through a subgroup of NGOs and its own funding mechanisms. In terms of that, then we see that what we can see of the two grants, one, Gavi is not complex because of the fact that it is integrated into the existing systems. But for Global Fund, we do have a quite complex system for those of us implementing, and the processes of compliance are quite huge. For example, we do know in organization, there was 1 year we had 3 audits. One was from YG, one was external, one was the principal recipient. Then we had monthly. The processes take too much time dealing with compliance, yet the Gavi, as I said, has integrated into existing systems, so does not demand extra accountability from the existing funding mechanism. Intam has really supported, especially the development HIV, TB, and malaria. And so the DHIS can give most of the data. The problem is most of the grassroots level are not able to input the data, and they rely on NGOs and others to support them in doing that. So that we need more funds in terms of grassroots implementation. For the supply system, as we say, this is done in a parallel fashion for both the Global Fund, as they have their own PMS systems. Pharmaceutical Management Information System is also separate, so there is no integration in terms of that. The drug supply is done parallel by both the existing mechanism, which are the main ones from Pooled Fund and World Bank, and the Global Fund have their own. Gavi is integrated, working through UNICEF and the state and the national level to supply the required supplies. So what we would think is that we do need the donors to harmonize the systems to work in integrated fashion so as not to introduce too much compliance activities for the implementing partners and for the local organization and the state at the local level. Thank you very much. I will be very brief.
That's wonderful, Andrew. Thank you for sticking with the 5 minutes. We had sometimes your voice was sometimes gone, cracky, but I think we got the message loud and clear. How South Sudan is a very specific situation because it's not a very stable country. That means that the donors are relatively more stronger than the government, and how Gavi is actually doing a better job of working through the government than the Global Fund, which is working more in parallel. So the next presentation from the country level is from Uganda, which is a rather more sort of established and strong Ministry of Health. Darrington Birwa is presenting from Uganda. He's a social worker by profession, and he has got a master's in social sector planning and management. And he is very passionate about health and human rights. He is currently working in Uganda as a program officer for the Center for Healthy and Human Rights and Development, focusing on research at the Department of Knowledge Management. So, Derek, what's the situation like in Uganda? The floor is yours.
Thank you very much, Paul, for this opportunity to be among the presenters, and I thank the previous speakers. I think most of them have highlighted the situations, and it's not any different in Uganda, apart from the fact that we have been a stable country for about now 36 years, and the health system or the health sector of Uganda has been very, very stable and making progress. However, we have all the funding mechanisms, that is GFF, Gavi, and Global Fund. For Global Fund and Gavi, they've been here for over 18 years, I think, 18, 17 years. And the GFF, we have been implementing it from 2017. So I would like to first acknowledge that these funding mechanisms have made some strides towards improving our healthcare system. For example, Gavi has introduced a lot of vaccines and immunization products that wouldn't have gotten maybe without it. So the national coverage is doing well. Then Global Fund, of course, as you know, malaria, TB, and HIV are epidemics in Uganda. So also work there has been very progressive. And of recent, the GFF, through its financing mechanism of the of results-based financing, has seen an improvement in the uptake of maternal health services around the country. However, as the report from Miria really concluded, these funding mechanisms have not really translated their alignment to the grassroots. We can all attest, and we have seen that very many global meetings they meet at, they pledge to align their work and operations and programmatic approach at the grassroots, but this remains at the global level, as of course Global Fund and Gavi are the investment in the investors group of GFF, and they also kind of campaign for replenishment of individual funds. This has been appreciated and noticed at the global level, but at the national or country level, there has been no, I would say, visible effort, like Ellen said, to see them coordinating and aligning. And this is true because they approach the Ministry of Health alone, like in silos. And I guess it also alludes to the fact that she spoke of DNA. Maybe they don't want to mar and brings the issue of attribution. However, if we are all looking at improving health outcomes, especially for the vulnerable, I think it's very, very important that they align their priorities, because they state they have the similar priorities. So this should not only stop at the global level. It should be translated down at the national and grassroots at the grassroots level to have visible outputs, like all the previous speakers have said. Also, the issue of domestic resource mobilization. I think all mechanisms look forward to or pledge to help the country improve on this domestic resource mobilization through various approaches, not limited to public finance management and other innovations. But however, in Uganda, in the recent 5 years, it has stagnated, and of recent, the last 2 years, it has been regressing. It's like the more funding they pledge to our health sector, the less the government is interested in proactively promoting domestic resource mobilization. And this affects PHC, it affects the primary healthcare system. which has most of the diseases. I mean, which contributes to most of the maternal deaths and morbidities and all the diseases that we experience here. So I think, to me, that is the most important thing that they should really collaborate on. Then also they spoke of M&E data and data sharing, best practices at the national level. We have also not seen that. But again, like Ellen said, maybe it's backroom coordination, but needs to be more visible on the ground so that it can have a better impact, even in aligning with other stakeholders that they call there, like the private sector and the civil society. Because if they align on their own and don't involve other sectors in this alignment, I'm sure it won't pan out very well, especially for the vulnerable populations. So Paul, I think within my time, I beg to stop here for that contextual kind of submission. However, we are also grateful for all the progress that they've brought to our healthcare system, which is very evident. We just want more alignment, coordination, and collaboration, as they pledge to do and promise to align. Thank you.
Derek, thank you very much. It was a wonderful contribution. We are slightly over time, so I'm going to rush into the opportunity to answer some of the questions from the audience, I'll just start with the question that actually sort of like had the most upvotes, and that is a question from Asha George. And that is a question to Maria. And Maria, I see that you're typing, so stop typing and just say what you want to say. But the question is, are there any governance indicators to assess the impact of the 3 Gs on governance of national health systems or in aligning donor priorities? And how could further transparency and tracking be encouraged? So Maria, if you're there, maybe a couple of reflections on that. Or Hendrik, if you're there. Oh, there's Maria. Maria.
Sorry, I'm here. It's not that easy to exit the chat. No, yeah, the governance indicators. I think it's a very good question, and I was thinking out loud, what should I answer? In the Global Fund, for instance, we are currently discussing indicators that measure at least country alignment and strengthening systems at country level through, for instance, including indicators on domestic investments of countries. Sorry, but the question is also, should we not include indicators that measure alignment to other funds, for instance? And I think that is also a very good idea. And I was just responding to Mariska in another question that we have already proposed in the Global Fund that joint health system strengthening funding or pooled funding for health system strengthening could be an indicator, or at least a goal to aim for as an indicator of the implementation of the Global Action Plan. And as we, at least the Netherlands, we would be very supportive of pooling that funding, particularly in countries where already a pooled fund is existing. And I know, for example, that in Ethiopia, there is a joint donor pool for health system strengthening, and it could be quite easy, that at least that's what I think in my naivety, that the Global Fund would channel its funds for health system strengthening through this existing pooled mechanism. It might be different for countries that do not have a pooled mechanism in place yet, or do have very weak public financing systems, but at least it is something to strive for. And yeah, so I will also remember this comment, and we will also discuss it in our global health team and see how we can push for particular indicators also to make sure that the global funds move forward.
Wonderful, thank you, Maria. I think we have time for at least one more question. I actually this is a question that either Hendrik or Ellen might like to reflect on, or maybe even Derek and Andrew. Martin Oranje is saying, most of us will support the plea for coordination of efforts and close alignment with country policy. In reality, though, there is often a huge gap between national policies and the reality at the lower levels of the health pyramid. And he's saying, with more coordination, is there not also a risk of further centralization and top-down approaches? And how do we ensure that coordination at the national level goes hand in hand with increasing autonomy and differentiation at the local and the subnational government, which is obviously a very real tension that we see in the field. Either Ellen or Hendrik?
Thanks. Happy to come in here briefly. Indeed, a good question, and no easy agenda. What I wanted to briefly highlight here is a joint mission which recently took place to Pakistan, which of course is a country with the central government, but then with very strong provinces having a lot of the decision-making power. And what this joint mission, so it was under the umbrella of the Global Action Plan, led by the PHC Accelerator and the Finance Accelerator coming in strongly. And what they did, they started at the national level, but then different teams went to the different provinces. It was a hybrid mission, so some teams really traveled on the ground, others joined even at odd hours in the day, sort of from the US and from Geneva, to have these conversations. And then they met back in Islamabad at the end to exchange views, and the provincial authorities were part of that. So I think that's an approach, trying to find solutions which are sort of adequate to the context and strengthening in a way the provinces in the implementation while having a centralized push. So this just as one of the examples, and that might also go to a question which came earlier, sort of on KPIs. I think there's no development of something at the global level, but maybe if you look into this Pakistan example, really learning from the country level, what can be these indicators. And pooled funds, Ethiopia, we focused on that in the 2019 progress report also as a good example of good alignment.
They're very interesting because it's such a decentralized country, right? With sort of like the health being the responsibility of the provinces and not the center. Okay, final question for Ellen. Short question, but probably very difficult to answer. The question is from Enrique Paz. He says, can we get a breakdown by disease contribution in our budget and in health system strengthening? And I think what he's hinting at is like in the presentation that you gave on the budgets, are you actually looking at health overall? Are you doing the same thing by disease? And how do you actually define health system strengthening if many of the disease-specific funds are also doing health system strengthening?
Yes, thank you. Thank you, Paul. Yeah, I responded in the chat that, yeah, we can. We are basically, again, we're trying to make this exercise as useful as possible to the country. So we're trying to support really mapping and tracking of resources to priorities identified in the National Health Plan or the associated investment case. So yeah, we can break it down often by health system strengthening area, by disease area. Sometimes it really depends on what the priority is in the investment case. I think the common denominator in all of the GFF countries is getting more money to front lines, primary care, because that is where ultimately, of course, all these diseases that we are focused on in the agencies care about are being delivered. So that's really where we try to push, much more than measuring disease-specific funding, trying to get at measuring whether money reaches that level of the health system. And I also want to flag that we are in the process of thinking how we can make this work program and the data more useful to CSOs. Well, at country level, they have access through this, but also at global level. And like Wemos, for example, how do we give better access to this data and make it a more useful data source for broader efforts of advocacy, measuring alignment, and holding all of us accountable? So this is ongoing, and there's more coming on this, and some suggestions of how we can we can open up this data source. But in short, yeah, it's possible to look in much more detail than what I presented on the slide.
Great, thank you. That would be very useful. Okay, so we have 2 minutes left. So I'm giving the floor very quickly to Mirja to give her final observations and plans for the future. The floor is.
Thanks, Paul. First of all, thank you everyone, because all the questions that we are receiving are actually very useful for us to build our framework for the next step of this project, which is to see what is happening in the countries. And it really helps our thinking. And I was really happy actually to hear today from the fellow panelists that they agree with our recommendation and they agree with the change of thinking and the change of narrative on how we measure and how we attribute outcomes and results. And it was great to hear as well from Derek and Andrew their experiences about how, on the one hand, these initiatives really can improve a country's health system, but on the other hand, how they can also increase burden, like with heavy reporting, as Andrew said, with duplication and fragmentation that came up at our Mentimeter. So we see that there are pros and cons here, and well, we want to go towards improving health system in the countries, and the 3Gs really can contribute with great potential on that. So as I said, thank you for the questions. We tried to answer some of it online. We tried to type. It was not so easy, but we will really take them into account when we continue the project. And I hope that this was useful also for CSO fellows to use this evidence for their own advocacy as well. And just to close that, we need joint advocacy for that, both at global and national level, to see the improvement there. So I'll stop here, and over to you, Paul, for the closing.
Okay, and while I'm closing and thanking everybody, the Mentimeter is open, and we would really like to get from those of you who are interested just 1 or 2 words what you're taking away from this webinar, what your feeling is, whether you think it's good, bad, you know, what you learned, what you missed. Put anything in. While you're doing that, I would really like to thank first and foremost the panelists, but also the audience for taking the time to listen to this very important topic. I would like to thank the Wemos and Cordaid colleagues who have been making this possible. Also the people behind the scene who were sort of like technically helping us with this, who have been preparing this. As Mirja said, the recording will be online. The report is online. If you look in the chat, there will be the link to the report, not only the full report, but also the 3-pager policy thing. And all the questions will be answered to the extent that we can. If not to you directly, then in the next iteration of this work, which is an ongoing a piece of work. So it's not over yet. We will be back, and we hope that you will join us in the next steps of this process. If you can share, Mirte or Rosanna, the feedback that we're getting, that would be quite nice. Then we can, for those of you who are interested, we can keep looking at that while we're logging off. Okay, thank you very much, everybody, and have a nice afternoon. Bye.